Hi, this is Daaboul, live from ACC 2022, and I'm pleased to be joined by Dr. Marcucci. Thank you so much for joining us, Dr. Marcucci.
Thank you for having me.
And today we're going to be talking about a hypotension avoidance strategy versus hypertension avoidance strategy in patients who are undergoing non-cardiac surgery.
Correct.
And this is part of the POISE-3 trial. So tell us, Dr. Marcucci, first of all, what's the hypothesis behind this study?
Okay, thank you. Thank you for the opportunity. So I'll start saying that there are many patients that go for non-cardiac surgery every year. We know this number, more than 300 million, right? And the vast majority of these patients will be on chronic antihypertensive therapy. And so far, the evidence is showing that these medications usually are continued perioperatively. On the other side, what we know is that in non-cardiac surgery, hemodynamics abnormalities do occur quite frequently, and in particular, more than 25% of patients we can expect will experience a clinically significant hypotension, so low blood pressure, during surgery, but even after. And so far, there is no clear evidence showing what is the optimal perioperative blood pressure management, including intraoperatively and also pre- and postoperatively, in particular regarding the chronic antihypertensive medication administration. So our hypothesis was that in patients coming for surgery, high risk of vascular complications and be chronically on at least one antihypertensive medication, a hypotension avoidance strategy versus a hypertension avoidance strategy perioperatively would decrease the incidence at 30 days after surgery of major vascular complications, which have been linked to hemodynamic abnormalities in non-cardiac surgery.
So how did you define hypertension, hypotension around the time of the surgery, and what was the strategy to avoid hypotension and the strategy to avoid hypertension?
Thank you for the question. So I should start saying that hypotension avoidance and hypertension avoidance was an easy way to define the two strategies, pointing out at the hemodynamic abnormality that each strategy would preferentially avoid, okay? In the hypotension avoidance strategy, what would happen is that patients would come for surgery, and preoperatively, we would manage their antihypertensive medication based on an algorithm. In particular, we would hold ACE inhibitor ARB that based on existing data, although with limitation, there is some suggestion that holding them would actually decrease the risk of hypotension and then maybe vascular events. So we would hold this specific class of antihypertensive medication, and we would manage the other antihypertensive medication based on an algorithm that in a stepwise manner would give the patients blood pressure medications, but only based on their systolic blood pressure, this preoperatively. And postoperatively, we would apply the same kind of algorithm. So we would hold this inhibitor ARB, and we would administer the other chronic antihypertensive medication only based on the systolic blood pressure. And intraoperatively, in the hypotension avoidance group, the anesthetists were to target a mean arterial pressure of 80 or greater, which is usually higher than what commonly anesthetists target in the OR. In the other group, the hypertension avoidance strategy, preoperatively patients were just given all their chronic antihypertensive medications. Intraoperatively, the anesthetist would target a MAP, a mean arterial pressure of 60 or greater, which is common practice. And then postoperatively, patients were just given their chronic antihypertensive medication again.
And what did you find?
We found no difference between the two strategies. So 14% of patients in both groups experience a major vascular complication at 30 days. And we found no difference in either secondary and tertiary clinical outcomes.
Any subgroup modifiers of effect?
So we did run 4 pre-specified subgroup analyses based on whether patients were chronically on an ACE inhibitor or ARB, whether patients were chronically on one or more antihypertensive medications, based on the systolic blood pressure the patients came to surgery with, and based on the NT-proBNP value measured preoperatively, and we did not find any interaction. So our primary results were consistent across these subgroups and also across two other subgroups, which were whether patients were chronically on a beta blocker or not, and the type of non-cardiac surgery. So again, consistent results across different.
Speaking of beta blocker, I know POISE has had a lot of role in beta blockers in the perioperative setting. Was there any effect of beta blockers or withholding beta blockers, or we all know about the controversy of initiating beta blockers. Anything related to the beta blockers in that study?
So I think it's an important comparison to make. So the main difference between POISE-1 and POISE-3 is that in POISE-1, just to remind people listening to us, is that patients were those were naive patients to beta blocker, right? So the patients were started on a new beta blocker around the time of surgery. Here was a perioperative management of chronic beta blockers.
So patients he's been already on the beta blocker.
Right. So, and what happened here is that when we look at specifically the compliance to the intervention and also how this translates into the actual administration of beta blocker, I should remind you that our hypotension avoidance strategy was prioritizing the beta blocker across the other antihypertensive medications. So it was an hypotension avoidance, but still keeping in mind the results of POISE-1, because in POISE-1, beta blockers did reduce myocardial infarction around the time of surgery. So what we saw is that when overall among the patients that were included in the trial, 45% were chronically on a beta blocker. And then in the two strategies, the difference in people that were receiving beta blockers was not substantial, but still there was a little bit of difference. So a difference of 9 to 11% of patients, meaning with that, and in the hypertension avoidance, more patients would receive their beta blocker compared to the hypotension. We could not necessarily extrapolate the specific effect of continuing holding beta blocker because these were multifaceted interventions, right? Complex interventions. So we might look at specifically into that in a post-hoc analysis, but we know that we might have limited power because this was only a piece of the intervention.
How do you think the results of the POISE-3 trial are going to change the guidelines or the way we practice medicine?
Yeah, so one thing that I should say is that, of course, our hypothesis was different. So we wanted to try to understand a little bit the results. And just to make a long story short, we did run additional analysis, which are important in the message that we're going to give. And we found that basically, eventually, our two interventions differ a little on the effect on hemodynamics. So very likely, the reason why we didn't see an effect on major vascular complications is that because the difference in systolic blood pressure and heart rate between these two groups of patients was not substantial. So the take-home message is that POISE-3 is actually informing two important questions that confront many physicians, many types of physicians taking care of patients coming for surgery, from cardiologists to internal medicine, I'm an internist, anesthetists, but also family doctor that see these patients before coming for surgery. And one important answer is that targeting intraoperatively a MAP of 60 or greater, or a higher MAP of 80 or greater, didn't really make a difference to major vascular complications. And second important answer, perioperative, so before and after surgery, holding ACE inhibitor and continuing the other chronic antihypertensive medication based on an algorithm on patient's systolic blood pressure versus just continuing hold the antihypertensive medication didn't have a substantial impact on hemodynamics and then eventually on major vascular outcome. So I think on average, POISE-3 is really providing the answer that these two different strategies do not make a difference on major vascular complications. And we did not find any significant subgroup effect. So based on POISE-3, I cannot say you should do this and this specific subgroup. This, of course, doesn't exclude that every physician can still have an individualized approach to patients. Absolutely, yes.
Well, thank you so much for sharing the results of the trial.
Thank you.
And thank you all for joining us live from ACC 2022.